So thank you very much for joining this morning. So this is a session on the NHS as a market that we're running from Health Innovation North East North Cumbria as part of the Tees Valley Innovation Challenge programme. Just so everyone's aware, the session is being recorded. And if you have any questions, please put them in the Q&A box or raise your hand as well. We will be giving time after all the speakers for people to ask their questions. And if we're not able to answer them, then we will get back to you. So just to kick us off, I'll hand over to Simon, who is the lead at Edge, and he'll introduce the Tees Valley Innovation Challenge. Over to you, Simon.
Thanks, Rusty. So, as Rusty said, Simon Green, I'm CEO of Edge Innovation. We're a specialist design innovation agency based in the northeast of England and doing work across, globally now in terms of innovation, helping people around new product design and new service design. I'll just click onto the next slide, please. The work that we're doing here is funded through UK Share Prosperity Fund through Tees Valley Combined Authority. And for those of you who are not massively aware in terms of what the authority does, it's the statutory body responsible for securing investment, creating jobs and ultimately transforming Tees Valley as a place for businesses and residents. If you can kick on to the next slide, please. And as part of that, I'm not expecting you to read all this, but it's they've secured some funding through the UK Share Prosperity Fund from UK government for supporting local businesses, for developing skills and supporting people into work, and for the development of programs around place-based development in communities of Tees Valley. And as part of that, the authority are funding programs that are designed to support businesses, help them to grow and help them to develop the economy locally, which is where this program comes in. You can skip on to the next slide, please. So if anyone wanted some more information in terms of those programs and how the authority has developed and delivered those programs, then it's on Tees Valley Combined Authority's website. What we're specifically talking about today, though, is the Tees Valley Innovation Challenge, which is being delivered through 4 different routes. Fundamentally, what we're trying to do is ensure that local small and medium-sized businesses can be successful around innovation, new product development. And we're doing that partly through innovation challenges, where we work with big organisations, including NHS trusts, on challenges they have, which we then publish and ask for responses from local businesses. There's one of those actually live on our website at the moment around a challenge with South Tees NHS Hospitals Trust, which might be worth having a look at if you're keen on working with that organisation. We provide one-to-one support for SMEs where we can help you to develop your own ideas and get them to market, identify new customers and de-risk that process of raising funding and launching new concepts. We work through innovation training, helping to build skills within organisations, including through this programme here. And we have a program of more general innovation training for companies to help you to de-risk innovation, get things to market quicker, help you work out what are the best things to be spending your time on. And then in March next year, we're running a big high-profile innovation showcase where local businesses can promote their activities, show off some of the innovative ideas that they've been developing, and attract new customers, partners, funders through that route. And that's a free opportunity for local SMEs, which we'll be publishing very shortly. For information on any of these items, I'll drop a link in the chat, which gives you a link to the information, and obviously sign up to our newsletter and we'll be able to share the information as it comes out. The Tees Valley Innovation Challenge is a partnership between Edge and with Health Innovation North East and North Cumbria. So Rusty will give you a bit of information on that organisation, and then we'll take you into the content for today. Thank you very much.
Thank you, Simon. So I'll just give you a bit of a brief overview about the Health Innovation Networks. If you can pop to the next slide, please. So this is me. I'm Rusty. I'm Programme Manager in the Economic Growth team at Health Innovation North East North Cumbria. So what are the HINs? So the Health Innovation Networks, there are 15 of us across England, and we were established in 2013 with the goal of spreading health innovation at pace and scale. So we work with healthcare organisations and businesses to support all types of innovation within the NHS, from new technologies to ways of working to service improvements also. And we do this to improve services for patients, to enable NHS efficiencies and to support economic growth. And we're seen as the innovation arm of the NHS and commissioned by the Office for Life Sciences and NHS England. Next slide, please. So we work both locally and nationally. So ourselves, our area and our remit is North East and North Cumbria. So we identify, empower and advance innovation at pace and scale. So we're sort of the interface between industry, healthcare and social care. We foster regional collaborations and partnerships, and we work with our partners in the ICB to understand sort of unmet needs and priorities, and to co-design and deliver innovation. And also to support sort of adoption and spread of local innovation, and then to import what works well elsewhere. And then nationally, we work together with other HINs to interact and exchange sort of best practices and ways of working. And then collectively, we come together as a collaboration with an authoritative voice to enable that all the work that we do has a greater impact as well. Next slide, please. So what do we do? So we focus on a few key areas in the North East North Cumbria. So transforming patient safety, improving population health, developing innovation, supporting economic growth, and then driving digital transformation. And we do all of this through our innovation pathway, which is sort of the core of everything that we do. And we identify, evaluate, adopt and disseminate transformative innovations. And we do this with sort of collaborations and partnerships, again, with sort of academics and healthcare trusts as well. So next slide, please. So at Health Innovation North East North Cumbria, we've developed this innovation pathway, which we'll go over in more detail in our next session, which is on the 17th of October. And it's sort of the vehicle for articulating sort of the bespoke services that we can provide to the NHS organisations and to industry as well. But as I said, we'll go over this in more detail and sort of all the pieces of the pathway in the follow-up session. So the next slide, please. So this is our agenda for today. So we'll have Ross Watkins talking to us next about the NHS as a market. Ben Porter will be going over the innovation service, and then Leanne Waring will talk about procurement in the NHS. And then we have a nice case study they'll be covered by Catherine Kelly and Tracy Marshall, about an innovation that Health Innovation North East North Cumbria has supported from sort of the initial idea through to adoption, called PocDoc. So I'll hand over to Ross, who'll take you over sort of the NHS as a market. So over to you, Ross.
Thanks, Rusty. Let's just get my camera on so people can see me. Morning, everyone. I'm conscious that there might be a mixed audience here of people who understand the NHS quite well, some who are completely new to the NHS. So what I'm going to do is do it as if you know nothing, and then if hopefully that will allow an element of learning for everyone, but also those who are familiar with the NHS. I suspect there is still quite a bit that it is still a bit of a mystery to you. If you've got any questions as I go, please don't hesitate to put them in the chat. What I will then do is towards the end of my slot, I will kind of do a Q&A session on anything that we've covered. So even if it's just a reminder of a question you had, put it in the chat, and then we'll pick it up at the end, if that's okay. I'm the commercial director of North East North Cumbria Health Innovation Network. my role really is to support all of the innovation work that we do. I've had 24 years within the NHS. So I know it quite well. I wouldn't say that I know it all, but I know it quite well. So hopefully what I give you today will give you a better insight into the NHS just as a market itself. Can I have the next slide, please? Just wanted to know how much you already know about the NHS. I've just put in the chat a couple of answers to the following questions, if that's okay. Next slide up. So I'm just interested to know, any of you have heard of, you might have heard the top one, you may have heard of the middle one. I'm highly doubt that you'll have heard of the last one, but that would give me a bit of an indication of, could you either put Darcy long-term plan or operational plan in the chat, or if you haven't read any of them or know about any of them, just say none. That would be helpful, just for me to get a gauge of who is in the room. Oh, we've got some that has all of them. Brilliant. Okay. Okay, that gives me a good flavour of who's in the room and to what level I need to go through these slides. Can I go to the next slide, please? So I'm going to test your knowledge now. For those who've all said all, see how much you know about what is made up of the NHS. So how many GP practices are there in England? Let's start with that one. Could people just put a number in the chat just very quickly? Or have I frightened everyone off now? There's no wrong answer, please. Unless my chat's gone funny. Anyone? Oh, 26,000, I've got a starter. Lower than that. Any more? So it's lower than both of those. 4,000 is much nearer. Right, I'll leave that one there. What does ICB stand for? I'll try very good, Guy, very good. I'll try and the NHS is full of 3 and 4 letter acronyms, and I know that Rusty already used the word ICB, and some people might not know what that is. So what does the ICB stand for? What does those 3 letters stand for? Does anyone know? So yes, Integrated Care Board. There is also something called the ICS, which is also a thing, and an ICP, and I'll talk about those in a little while. So I thought I'll give you the answer to the GP. Next slide, please. Sorry. So at the bottom, halfway down, you'll see that there's 6,311, and that goes down by about 10% every year. So GPs are either retiring and bigger practices are created, or they are merging, and therefore they are obviously reducing in size. So as of like 9 months or so ago, there was 6,300. So Guy, I think you win to being closest. So the NHS is not one thing. So I suspect most of you know that, but it's made up of a lot of individual organisations, and these are the ones that just deliver care, let alone all of the other organisations that then do stuff around it. I'll go into the integrated care boards shortly. The difference between foundation trusts and acute trusts is not really that important, but what all it does is it allows hospitals to have more independence on what they can do with funding that they get, and also how they're governed, whereas acute trusts are essentially managed by NHS England, and they have less say about how they can do things. Within the numbers of trusts, there are 10 ambulance trusts, and I think they're all foundation trusts now. It might be that there's only 5 still remaining. Community providers. So the last big shake-up of the NHS that happened in not this one that's just gone to create ICBs, but the ones that created clinical commissioning groups. Provider organisations were created to provide community provision as organisations in their own right. Some are managed by, so locally in Gateshead, you've got something called CBC Health, and that would be one of these types of community providers that's been created. A lot of them, though, are managed, as you can see, by NHS trusts, and occasionally these will go out to tender, but I haven't seen one out for quite a while. So CBC Health is the limited company that actually appears on that list. You've also got mental health trusts, and certainly in London and in Liverpool, there are specialist trusts that just do one thing rather than so in London, you've got like an orthopaedic hospital and an eye hospital. In Liverpool, you've got a women's and children's hospitals. So, you know, there are different organisations depending on what you want to do. I'll talk about primary care networks in a second. And then there are a number of different organisations that are, some are for profit. So these are either voluntary sector organisations that also provide services, and that will be from very small services up to the Bupa and Spire type hospitals that provide also NHS care as well as private care. Next slide, please. It's important to know what these ICBs are, so integrated care boards, and you'll sometimes see them as ICSs and you'll sometimes see them as ICPs. So if you see any of them, you can refer back to these slides, because the slides will be sent out, so you can have a look at these. So the main difference between the ICS and the ICB is when you're talking about the ICB, it's the statutory organisation. So if you had a contract with our system, for example, which is number 2 on the blue map, that would be come from the ICB. But when you're talking about the system of care, people generally talk about it as an ICS. But increasingly that's sort of being phased out. So and ICPs are more around the partnerships that at a local level. So these are far more around place-based. So in the Northeast, for example, we've got 4 integrated care partnerships, and they are groups of organisations that work together around a particular geography. So you might see those 3 things interchangeably, but largely it means either at place-based or at system level, or it's a statutory organisation. As you can see, there are 42 in the country. Been rumours that some of these might merge, but I haven't heard that for a little while, so I think that's quite a stable thing. But I don't know with the new government whether that's something that will take place or not. Next slide, please. Why is it important to understand what an ICB is? So they've got 4 broad aims. The first is to look at how the population and healthcare are developed, how you can look at the outcomes of patients, how you can look at particular sectors of the organisation, or look at how population health changes depending on on the demographics of the of who lives there or the area. Within the Northeast in particular, we've got significant areas of deprivation, but generally our healthcare provision is very high and very well looked at nationally as a cohesive system. But actually, we've got some of the poorest health outcomes in the country. Despite having good healthcare, our patients, there is still need to do look at the data and look at how can we improve those population health. The inequality element, just sort of interchangeably talked about there, but this is how you tackle particular inequalities. Now that might be around particular characteristics of a population, or sectors of patient groups, whether that's from a sort of a religious point of view or from an economic point of view. What we need to look at is how do we get to reach what they call hard to reach people, which don't necessarily engage with the NHS in the way that it was probably set up for very much a white sort of middle class, I would have imagined, system. But there is a big requirement for us to look at equality of care and make sure that the patients get the same experience no matter where they live. This is one of the hardest things, certainly for the Northeast, to tackle in terms of inequalities, because our inequalities within region are or our care outcomes in region vary quite significantly. But then when you look at affluent parts of the country, we compare significantly different, even as a region, let alone as pockets of the region. They look after the money. So if you look at sort of an organisation like Newcastle Hospitals, for example, you're talking, and probably Northumbria, you're talking about organisations that contracts are over £1 billion. And so you're not talking about a small amount of money. So it's the ICB's job to look at how do we get the most for the money that we have, how do we get that value for money, so that they need to look at, are we spending the money in the right way to tackle 1 and 2, basically. And the fourth one, which is one that you hear not as much about, but certainly with the new Labour government, you're hearing a lot more about, is how do you use the NHS and the power of the NHS, whether that's buying power or the amount of people they employ, as a stimulation of economic growth. So how can we support our local industry to buy locally? Whether that is food or whether it's widgets that you put in somebody, or diagnostics, or whatever it is. What we need to look at is, can we, as an NHS, be more responsible around the social and economic development within an area? They call them anchor institutions. So the big universities, the hospitals, and the local authorities do see themselves as significant employers of the Northeast in particular. That might be less so in other parts of the country, but certainly in the Northeast, it's I would say those 3 elements themselves will take up quite a lot of a percentage of people employed in the Northeast. Next slide, please. So what do they commission? Sorry, the title of this has slipped slightly. I've listed their statutory duties, so I'm not going to go into that, but you can look at that afterwards. So this is all of the stuff that they buy. Importantly, that is most of the healthcare provision within any sort of setting. So it'll be the all of the hospitals, GP practices, ophthalmology, so opticians, dentists, pharmacy, all of the activity that happens in the community, the ambulance services, etc., the funding will all come from the ICB, and generally they're done through national contracts, and you will see that from that list it's quite a exhaustive list of healthcare. The bits that they don't commission, I'll talk about, I think, in the next slide or the one after. They're an important bit of our system, and certainly as an innovator, you need to understand which bits do they commission, and are they then going to be the commissioner of your innovation, or is it through a different service that you might need to go to a hospital to get your innovation actually bought, because that's where it's used, and that can get a bit confusing sometimes, and that's why organizations like mine exist, so we can take you on that journey of who is actually going to buy what you want. Ultimately, the money comes from the ICB, but actually they might not be the ones who benefit from your offering, or they may not actually be the ones that buy them. So it's a little bit complicated, but I'll try and show that with I think it's the next slide. Could we move on to the next slide, Anna, please? Oh no, it's a couple after. So it's important to understand that you've got 42 different health systems who potentially have 42 different sets of priorities. So if you think that your widget is being bought in one part of the country, and you think, great, now all of the NHS is going to buy that, that isn't necessarily the case, because it will depend on whether the priorities for that year or that 3 years, depending on the document that you're looking at, they will dictate what they're likely to prioritize in terms of spending money on new things, on innovation. And even if you're saving the NHS money, they may say, well, actually, that's still not a priority for what we want to do. So it's really important that you get to understand what are the different drivers of ICBs. Currently, and quite annoyingly, that is not, well, I haven't seen anywhere. If you have, put it in the chat. I haven't seen anywhere that is documented in one place to say these are all the priorities across the country, and you've got the ability to sort of be able to dive into that data and see what that looks like. So it probably will require you doing a lot more digging into, and all of these are publicly available. So this is the Northeast one, which is the better health and well-being for all. This is ultimately this is their health strategy. So you could go in there and have a look at, do your strategy align with theirs? Does your widget align with what they want to do? So it's a good starting point to look at how does the region, what are potentially the priorities in each region. Next slide, please. So the money flows. Again, I'm not going to go into all of this, but there are videos and other things which I'll put. There's a page with some links on which you can go into and have a look at. So the Department of Health will fund things within certain sort of buckets. So you've got things like the Care Quality Commission, so CQC. You'll hear about that in terms of ratings of hospitals, and recently they've been talking about changing the rating, what the ratings stand for, because actually it can be a little bit confusing around what's the difference between outstanding and good, and how do they define that better. So Public Health England got disbanded as part of within the pandemic, if people will remember, and that basically has reborn as a UK security agency. So funding will go to there to look at how do we deal with pandemics, epidemics, and things like all of the screening campaigns. They have, so all of the cancer screening programs, the flu vaccines and stuff like that will all be overseen by them. There's quite a lot of money. So billion, I think, or it might be more than that, goes into research and development, and NIHR, so the National Institute of Health and Care Research, deliver that program. So most of the NHS funding for healthcare goes through NIHR. There are other funders, which if we've got time we can go back to. So NICE, you potentially have heard of. They set some of the guidance and requirements for the NHS to use certain drugs or certain pathways. They do a lot around clinical pathways and looking at what innovation sits within those pathways. So funding goes to them, and the funding then goes to NHS England, which has recently consumed things like NHSX and Health Education England. They used to be separate, but now they're all part of NHS England. And there are three types of funding that comes into that. You've got local authority funding around the prevention agenda. So it's a local authority statutory duty to fund prevention, for example. Specialised commissioning, they look at low volume, high cost things, whether that's drugs or whether that's devices or something else. And then you've got integrated care boards, which, as I said before, take up quite a lot of the funding of the NHS. And you can see which bits that they fund, as I talked about before. So that gives you an idea of how the money flows and what different pots of funding are available and how they're disseminated. Hopefully that makes sense. Next slide, please. I don't know what's happened with the things on there, so I'll reformat it before we send it out. In terms of where can you get some information about some of this stuff? So if you were looking at how do I understand what some of these challenges look like, I'll come back to the fingertips and Atlas of Variation as an example of these. But you have things like the NHS Business Authority. So if you're looking at prescribing data, they've got open source prescribing data. Obviously, it doesn't go down into as much detail as the NHS has, but it will give you an idea of what is the prescribing habits in certain regions and how they differ. So that's all available in terms of dashboards, and I believe you can download certain information for you to be able to do yourselves. If you were looking at GP and primary care in particular, there's a brilliant quality and outcomes framework link that will take you to understand what different prevalences are, and that can take you down to locality level as well. It only looks at the things that the GPs have been incentivized to do, and they are paid for particular activities. But it will certainly, if you're looking at anything in terms of long-term conditions, that is a good place to get data. I talked about the operational framework every year. So NHS England Department of Health will set what are the operational targets of the NHS. They normally publish it on Christmas Eve to give everybody a lovely Christmas, and it sets the priorities for the NHS for the following year. So it will, we will receive 2025-26s around Christmas Eve, and they will set if you're looking at what is going to be the hotspots within the NHS over the next year, it is quite a useful document to at least get your head around. So I've got the link for that. You can see what previous years look like, and obviously next year's will be up shortly. The long-term plan that got refreshed in 2022, but this gives you a much better idea of what the vision of the NHS is. Where do they think it's going to, where is it going to go? I think that will be refreshed again as part of the Labour the change in government, they're going to have a 10-year plan, which I don't think is the same as a long-term plan, but this is very much around how do you deal with long-term conditions over a much longer period of time. So not just over one financial year, but an understanding that the NHS is going to have to invest in that over a longer period. So there are useful links there. And again, you can just click on them as you require in your own leisure. Next slide, please. So as I've talked about before, the NHS is different, there are some tools that will allow you to look at the differences in those different ICB areas, this is called fingertips, so it allows you to drill in to them, and it will give you maps, it can give you data, but it will look at a lot wider things like, you know, if your innovation was around saving, improving workforce pressures, or if you have workforce pressures in a particular area, it will allow you to look at what the staff skill mix is in particular geographies, and that might give you an indication of which system might be the best one to go and have a discussion with about your innovation. So it gives you a lot of detailed information around priorities. This one that was around affordability. So this looks at how much cash do they have that they use for innovation or other things like that. And you can see where areas that you might want to avoid and areas that might be a bit riper for maybe taking a punt on an investment and an innovation. It just gives you ideas of where to start, because sometimes it's really difficult to know which area is the best one to start in. Next slide, please. Again, you've seen this before, but the only thing to note, which is slightly different on this map to the other, is the way that NHS England is governed. If you remember the flow diagram, the one on the right was at the regional level. So each of the ICBs are linked to a region. So our region in the northeast is northeast and Yorkshire. So there are 4 ICBs within that. There are 3 in Yorkshire, and there's ours in northeast North Cumbria. So that region is defined, and there will be particular focus on what are the priorities within the region. So it allows slightly more flexibility around what is the local priorities that NHS England will look at. So next slide, please. So what does that mean for you guys who are innovators? Probably even by me explaining some of that, that seems complicated. It also, if you think that the NHS is going to behave in a particular way, it probably won't. I've been in situations where I've said this is a no-brainer and it still doesn't get bought, or it still doesn't get, because it's not a priority for that area, and they want to spend all of their money on that particular priority. The other problem you've got is, we call them unmet needs. You could call them demand signalling. Demand signalling is very much an NHS England language for what are the problems the NHS needs to solve locally. Sometimes you don't know because the NHS doesn't tell you. Sometimes it could be very misleading in terms of it's a priority for a particular geography, but that isn't necessarily across the whole of the NHS. And it's not written in a way that innovators necessarily understand. And our role within health innovation networks are to take them and put them into a language that you understand. So one of our goals is to get better, the NHS to get better at talking about what their needs are, because it's far easier to put an innovation into somewhere that they want it, rather than you pushing it in. So that we talk about push and pull. So if you're trying to push your innovation onto a region and it doesn't meet their priorities, that's not going to be that easy. But if the pull is from the NHS and you know that need is there, you've got a much better chance of your innovation being adopted. Because the staff, because there's so many staff, I guess, within the NHS, a lot of them will not have experience of working with industry. Some will believe that industry is a move towards privatization, and they're quite anti-industry. That's more largely pharmaceuticals and big diagnostic companies are probably more wary of, rather than small businesses. But there is that sort of industry or a bit of a dirty partner to some NHS staff. And what we're trying to do is say, actually, they are the ones that are nimble and be able to give you what you need. So this is why you need to work with them. And as I've said, and I'll carry on saying, the success in one particular geography does not mean automatic spread and adoption. But we have means and ways of being able for you to describe what your offer is, and for that to have a better chance of adoption and spread, because we would be able to provide that to the other 14 within England, as Rusty talked about before. There was 15 of us, and the whole idea is, if it works in the northeast and North Cumbria, what is the recipe for that, and why has it worked, and what are the standards, what are the drivers? And then we should be able to take them to the 14 and say, which ones of you have the same drivers? Let's try there first. So you can adopt with a better strategy than just saying, right, it's worked here, we're going to sell it everywhere, because that doesn't really happen in that way. Next slide, please. I guess the NHS has a different problem, and this is what you need to kind of work through is, how do they know what you're selling? So, are you targeting, is your PR stuff that you've got around your innovation generic? Is it aimed at clinicians, or is it aimed at patients, or or are you changing your narrative depending on who you're trying to sell to? So who are you trying to get on board? If you're trying to sell to a procurement team, what their drivers are will be different to what you want to sell. If you're trying to engage with a clinician, they're not interested in the money side of things generally, but they are interested in, does it add value to the patient? I talk about a faffability index, which I'll go on to in a second. But what I'm trying to say around this slide is, if you have a slide deck, and you have one slide deck, and you use that with innovation, to sort of sell your message, you need to maybe think about that in a slightly different way. And I'll talk about, there are a lot more slides to this slide deck, but I'll take you through probably the first one to give you an understanding of what I mean by this. And then the others you can follow quite easily. So if we move to the next slide, this isn't a word, but I am determined to get it into the English dictionary as a word. But faffability is something that I see all of the time with innovations, and it's the single thing that might make your innovation work. So, sorry, if you imagine a pebble in a pond, you chuck a pebble in a pond and it ripples. What I'm imagining is your your pebble is your innovation, and your pond is the system that you're trying to get your innovation adopted into. If you do you understand what is the ripple effect of your innovation, upstream and downstream? You know, who's going to be affected by it? How are they going to be affected by it? And how big is the waves or the ripples that it affects? So if you imagine, you know, Lake Windermere, and you chuck a little pebble in, you might not even really see the ripples. But if you've got a boulder and then you chuck it into quite a small pond or even a puddle, you will displace the water quite quickly. And what you've got to understand is how does this work? If you have an innovation that is great, but it requires 10 days of training, and it requires that training to be every year, then quite frankly, the NHS isn't going to buy it, because they won't send people out for training. You might get away with half a day maximum, but if it requires that, you're not going to do that. If it requires a clinician changing the way that he does something or she does something with a patient, they're only going to do that if the innovation is really outstanding. Otherwise, they will much prefer to do what they've always done and understand that it's not as good as it could be. And what we can do with this is look at getting the right balance of your ripples, a real understanding of how your innovation either disrupts or kind of makes a small difference. If it makes a small difference, the NHS won't buy it, because they'll say, what's the point? It means that I'm going to have to change what I do, and it doesn't matter if it's slightly cheaper, the clinicians won't use it, because the clinicians aren't interested that much into this is going to save the NHS money. If it's like you're changing a drug in a syringe from that one to the other one, and it does the same thing and the outcomes are the same, they will change that. But if you're then going to change that to an IV, or, you know, I know that's maybe never going to happen, but, you know, you understand the point that I'm making is they're going to have to get a stand, they're going to have to put it on, they're going to have to get the person in a drip, they're going to have to then take it out and stuff like that. So if your innovation is so much better for patients, but it requires them to shift what they are doing, clinicians to shift what they are doing, it is really hard to get your innovation implemented. So what we tried to do is really kind of understand that, get feedback from clinicians, and really kind of drive that forward. Next slide, please. Right, I left this because I didn't know how long this was going to take me, and I was looking at the chat, and there's not that much in the chat at the minute, so I'll be able to kind of just maybe flip through maybe one of these or two of these, but the rest of them are there. If you could switch to the next slide, please. When you're looking at your messaging in particular to the NHS, I look at it in the lens of it's not quite 4 customer segments, because the ones underneath, you know, I kind of tried to make it 4, but it's probably about 8. And there is all 8 here, so you've got a bit of an understanding of that. But if your messaging does not appeal to these groups of people, and you've thought about it in terms of changing your messaging, then it's really much harder to get your innovation implemented, especially if it's got you know, I know not all innovation is patient facing, but the majority of it is. But if it includes a clinician or a user or a patient, then you've got those elements to think about, and then it's what are the other things that people want to see. So if you go to the next slide, I'll give you an example of this. So if you've got a clinician, so your innovation is largely going to be used by a clinician. Have you got an understanding of how it will be used. So do you know what they currently use now? Do you understand what the current gold standard should be? Whether there's nice guidance around that, or there are other, some of the colleges have guidance on particular things. Do you understand how it's used now? Do you understand how you would want this to be used? And are you able to articulate that in a way that the clinicians can quickly understand, and they can work in their heads, oh, okay, I have to do this instead of this. That makes sense to why I'm doing it, and I'm able to kind of, they visually can comprehend that. Do you understand what's important to that clinician or the end user, and that engagement between the patient and the clinician when they are using your innovation? Is it clear that this is going to help, this is going to enhance? Do you understand how that, if your things takes 20 minutes to do, or you get a readout after 20 minutes, but the appointment's only 10 minutes, that isn't going to work. You've straight away got then either an admin burden, or you've got a problem with how are you going to then get the results back to the patient? Is that an extra appointment? Is it some other way in which that's going to have to be delivered? You've really got to understand and get into that user journey. And I've said, have you applied your index? So have you worked out how long it's going to take, what training's required, what information leaflets are available? Are they available in all languages? What happens if somebody doesn't have access to the internet? If it's an app, if your thing's an app, and 25% of the people going into that clinic don't have access to an internet or the phone, then that ain't going to happen. And it's more around, do you understand that context of that interface? If your clinician needs to log on to a different system to see the results, rather than it integrated into its own clinical system, that isn't going to happen. Or it would have to be remarkably good for them to want to do that, because they just don't have the time. They don't have the inclination to remember another password, another thing on a computer. Is it on that computer that they're using? If they go to a different clinics, is that still going to be there to be used? So it's really, I know this might sound like I'm being quite sort of melodramatic about these things, but it is really important that you understand this interface between the patient and the clinician. If you move to the next slide, I'll maybe do one or two more, and then I'll stop for questions. So that's one bit that you need to think about. You also then need to think about, okay, what is the evidence behind this? So if a clinician's going to use this with a patient, they're going to want to make it safe, make sure that it's safe, that it actually is more productive. So is it quicker? Does it stop you doing something? Is it easier to use? Is it, all of those things? Does it have the same standard? If you look at point of care testing in particular, the big stumbling block around that has always been, but it's not as good as it being done in a lab. So why would I move to that? Now, if it means that you can get results in 10 minutes rather than it being 4 days, then they'll listen to that, and they'll understand that, yes, it's not quite as good, but it actually gives me the same results that I need, and it's in a tolerance that they're happy with. If you're looking at changing the staff skill mix, so if something can be done by a lower banded staff, which would free up the consultant or the specialist nurse by an auxiliary or somebody else doing something, does that matter to that organization? Do they have people that they can just bring in to do that? Is it as straightforward as that? Or what does a consultant need to think about? Do they need to change their clinic to be able to say, right, I'm not going to be doing that as part of my clinic. but I'll be having the results and I'll need time to look at them, etc. I've talked about training, I've talked about interoperability, but maybe just quickly go to the next one, which is the patient, I think. So from a patient point of view, is they will be interested in, well, what's going to change with my care? So if they're used to going to a certain appointment, seeing a certain person, being asked a certain questions, and then they don't go and see that person, they're asked different questions, and they, the whole thing is different. They will go, oh, I don't quite like that. If they used to see the GP and now they're seeing a nurse, they'll go, well, oh, I'm not really being seen by the person that I want to be seen by, which is the GP. So how do you convince the patient that that's better? Inequalities I've talked about, in terms of especially digital, and people will say, well, everyone's got a smartphone. Okay, well, there are people that don't have a smartphone. There are people who don't have Wi-Fi or the internet. There are people who wouldn't even know how to use a phone, even if they had one. How are you going to do the training around that? You can't increase inequalities. So if you're going to put an app in place, what do you do for those patients who aren't going to be able to use the app? Next slide, Hannah, please. And then these are the things you then need to think about is, does it impact the quality of life? If it enhances the quality of the life of patients, how are you articulating that? We've talked about poverty. Language is a particularly difficult thing, and especially the different dialects of languages, and making sure that it's translated in a way that actually they understand. Are you working with local faith leaders to, help them to articulate that message? Are there cultural reasons why a particular innovation won't be liked by a certain community or a certain thing? If it means that you're no longer, the district nurse doesn't go out on a daily basis to see Betty, and it's the only person Betty sees on that day, have you thought about that? Have you thought about, does that increase social isolation? Doesn't mean to say you shouldn't do it, but it's do you replace that with something else? Are you able to still allow that person to get some interaction with somebody, but it's not necessarily face to face? Training, interoperability, all of those things are important, especially when the NHS is wanting everybody to move over to the NHS app. Can your app be integrated into the NHS app, for example? Do you know where to start with that? Do you know who to speak to at NHS Digital? How do you start engaging with that? Because if you just go with an app, patients don't want 30 apps on their phone because they've got 10 different things, and none of them talk to each other, and none of them do this and none of them do that. How does that get integrated into the GP system and to the onto the NHS spine? All of those things need to be thought about. I'm going to stop there. There are ones like this for each of them, and you can just read through them. I think most of them make sense, and some of it is the same. I'm trying to deliberately say, have you thought about the faffability? Have you thought about the ripples? Have you thought about this? Have you thought about that? Some of it's common sense. Some of it is there to really kind of, you might say, well, social isolation, yeah, that's going to be a couple of patients. It's not important. It depends on what you're talking about, and it then becomes really important. And what you're doing is transferring your problem to local authorities, not the NHS. And then that causes loads of problems between the NHS and social services just by them adopting an innovation. If you're putting a different care package in place because of your innovation, you really need to understand that. So I'm going to stop there. I could talk about this for hours, and I've been told I only had 50 minutes, so I've stopped at 50 minutes.
Thank you, Russ. Has anybody got any questions for Russ whilst he's here? Or you can pop them in the chat or put your hand up.
Was there anything that I didn't talk about that you wanted me to talk about? I think the only thing in the chat is, can we share the information about the two maps? Yeah, there's a link to the Fingertips website in the slide so you can see that. That's not a problem.
Excellent. If there are no more questions, you can either follow up. Oh, no, sorry. There's a question from Callum in the chat.
Is there a cloud bias? Oh, okay. Do you mean, Callum, in terms of that, is there a preferential one that the NHS uses? I.e., if you're looking to put something on the cloud. There isn't, that all three are used. The main issue is where is the data stored? If it's stored outside of the UK, then that is more important about which platform you use. So all three of them are used. All three are big. I think Azure is probably more used than the other two, but equally the other two are used by the NHS, and I don't think it particularly matters. But if you say that that data storage is in Europe or it's in the States, or that you will, that's just a no-no. They will automatically, they'll want to know, is it safe? Is it you know, have you done your DTAC assessment? You know, those kind of things. Callum, does that help? Okay. Anything else?
Great. I think if there are no more questions, thank you very much, Ross. That was really, really interesting. And we will share all the slides and the recording after this session as well. So next on the agenda, we have a pre-recorded session from Ben Porter, who will go over the NHS Innovation Service.
Hi everyone, my name is Ben Porter and I'm one of the Programme Managers here at Health Innovation North East and North Cumbria. Within my role here, it involves providing innovator support to academics, SMEs, NHS innovators, alongside managing leading the NHS Innovation Services needs assessment function as well. So today I'm going to present on the Accelerated Access Collaborative, which provides a number of innovation opportunities alongside the NHS Innovation Service, which is one of their flagship programs. So just to give some context around the Accelerated Access Collaborative, so you have NHS England and Improvement, and there is the Innovation, Research and Life Sciences team. Essentially, they work as part of the Transformation Directorate within NHS England, and they support the NHS to implement the research and innovation strategy in the NHS's long-term plan. And they also support the delivery of the Accelerated Access Collaborative's priorities. So as you can see, the IRLS team, they have 3 missions here, which touch on some of what I've just said there, alongside improving NHS research efficiencies, as well as helping accelerate the adoption and spread of particular innovations to help get the best treatment for patients quicker. The IRLS also hosts the Accelerated Access Collaborative, and the Accelerated Access Collaborative, known as the AAC, brings together a number of key stakeholders, which includes industry, the government, regulators, patients, and the NHS. And their role really is to remove those barriers to ensure that those groundbreaking treatments can, treatments and diagnostics can be brought to the NHS faster to help improve that patient care. So here you'll see a bit of an infographic of the Accelerated Access Collaborative and a number of their key programs. So key programs and infrastructures that they provide. So you can see that towards the idea stage of development, there are a number of funding opportunities, including the Artificial Intelligence Health and Care Awards. There's things like the Clinical Entrepreneur Programme, which you may have heard of. And as you move through a proof of concept, there's the Small Business Research Initiative for Healthcare, known as SBRI, which again is a funding call, which often it's thematic funding calls across different phases of development that you can apply for. And then as you move towards real world testing, you have things like the NHS Innovation Accelerator. And towards the end, kind of around adoption and spread, there's things like the MedTech funding mandate, which I'll touch on towards the end of the presentation. And the kind of wrap around for that whole phase of development is the NHS Innovation Service, which is a large part of this presentation will involve me talking about, which is one of the flagship programs as part of the AAC. So the NHS Innovation Service, so kind of let's give you a little bit of context as to why this has been set up. So there's a number of challenges faced by innovators when they're developing new innovations for the NHS and social care. So it can take up to 10 years to actually get into the NHS for a start. Also, there's a bit of a complex pathway in order to develop your idea and get it into the NHS as well. So it can be quite difficult to understand and navigate the various organisations or milestones that you need to kind of reach in order to get the innovation in the NHS. And quite often as well, innovators aren't fully sure on what they need to know as well. There's also a bit of a lack of collaboration between organisations as well as innovator to organisation as well. And then sometimes you can find that you spend a lot of your time knocking on doors and repeating conversations with, who you should be speaking to and not knowing who you should be speaking to as well. So what is the NHS Innovation Service? Well, the NHS Innovation Service essentially can offer practical advice to all types of innovators across the kind of spectrum of health and social care. It provides a centralized record of your innovation, so it avoids that duplication that we often see. It also, as a service, offers free advice and guidance offers free guidance and advice from experts within the industry. So a number of those organisations that are on the right hand side of the slide there, they have key people within those organisations to help advise you as you're developing your innovation. And also, given the service that Hyneng and Health Innovation Wessex co-lead, which is the needs assessment service, we provide a free expert needs assessment for you as well. So it means that we can see kind of what you've developed and what stage of development you're at, and we can advise best on what we think the next steps are and link you up with those relevant organisations. So if we move to who is the service for, so the core target user group is innovators, in particular industry, SMEs, clinicians and patients. What is the remit of the service? Well, it covers, as I said before, a range of innovations that are relevant to health and social care, which includes medical devices, digital technologies, AI, diagnostics, various service redesigns, and also models of care. There's also estates innovations as well. When should you come to the service? Well, it's there for those who are developing their idea, you want to scale your idea. It really is there for any stage of development for the most part. Where do you have to be based? Well, you can be based in England, Wales, Scotland, Northern Ireland, but also is open to international companies as well. It's quite a broad service in terms of who can support. So what are the benefits of engaging with the service? Well, as I mentioned before, there is joined up support from being within the service. So we can link you up with relevant organisations. That's plural, so multiple organisations at the same time. It also reduces the duplication of effort of having those conversations because you have that centralised record, and it's a dynamic record as well. So it means that when you're developing your innovation, you can go back into that record and make those relevant updates so the organisations on the service can see how you're progressing. There's also quicker access to support as well because we have within the service specific what they're called qualifying accessors and accessors for each organisation, so you know that you're speaking to the right person. There's also an increased transparency and accountability through the service as well because each of those organisations will be updating the system as they're providing that support as well. So it means that between organisations they can see what's going on, so you haven't got to duplicate those conversations as well. The service also facilitates horizon scanning, so it means by being on the service you're potentially there for other organisations to pick up communications with you proactively. For example, if they've got specific clinical themes within their ICBs, they may want to look at innovations within that particular area. So there's opportunities there for horizon scanning. And then also the ultimate aim of the service really is to get the best innovations to patients and to the NHS quicker as well. So accelerating the pace in which we can get those out to the relevant people who will use them. So how does it work? So the service, we have innovator guides on there. So there's innovator and innovation guides on there, which really outline how to develop an innovation with NHS and a number of the key obstacles or hurdles that you may have to face and navigate, with various links to resources on there as well. There's also some funding opportunities on the service website as well, which can be shared. We also include case studies on there as to how certain innovations have came to the service and what support they've received through the service. And there's also relevant news on there as well. And then the other bit is obviously accessing the innovation service by creating an innovation record. So this just outlines some of that process. So it's definitely worthwhile reading the innovation guide before you start, and then creating your account and completing that innovation record. And then once it's been submitted, it comes through to our team, which is the needs assessment service. And then we're able to provide that expert needs assessment in order to really allocate you to the relevant organisations who can provide more focused support, advice, signposting, and they can tell you what the next best steps are. So this is just an outline of the innovation record and the key areas that you will be expected to complete. It doesn't necessarily mean that you have to know all the answers, but you will have to complete each of these sections. So this includes the about your innovation. So kind of, apologies, I went to the previous slide. Apologies, I can't go back on the slides, but I will talk to the previous slides. So you'll be expected to complete an innovation record, which includes a number of key sections, things like, you know, the description of your record, your value proposition, your regulatory approvals that you may or may not have, whether or not you've got evidence or if you're deployed. And then what we're able to do is provide that needs assessment and refer you to the relevant organisations. Within the service, we do have organisations such as the Health Innovation Network. So that's 15 different health innovation networks from across England, and they can provide support, really helping you understand your idea, you know, the context in which you're trying to develop this. So helping you understand your value proposition, some of your market research, the evidence generation required to get into the NHS. There's also the NIHRs on there, which really they can help you understand the relevant funding opportunities that are available, but also how to generate evidence that will hopefully provide outcomes for the NHS. There's also the Health Research Authority. So if you're kind of new into the research space, they can really guide you on, you know, navigating data and research governance, going through ethics approval. There's also 3 health technology assessment organisations on there. So you'll have heard of NICE before, but there's also their Scottish and Welsh equivalents on there. So if you're a really late stage developed idea, you'll want to engage with them. There's also commercial services that they provide. There's also a Welsh equivalent of the Health Innovation Network called Life Sciences Hub Wales, as well as the Department for Business and Trade as well. So if you're looking at exporting opportunities, as well as them, there's also procurement organisations on there, such as NHS Supply Chain. So again, we can link you up with them so they can inform you about the relevant tenders or about their dynamic purchasing system. So yeah, it's a bit of a snapshot of the organisations on the service. Apologies, the slides won't go back to that, but you get the gist kind of from what I'm talking about there. If I just show you this slide here, this just gives you a bit of an overview of the service. So the service has been running for over 2 years now. So we've seen innovations from 45 different countries. 97% of the innovations start receiving their tailored support within 3 weeks. To date, we've had over 750 innovations come through the service, and every innovator will be referred to at least one organisation for support. On average, innovations actually receive support from 4 different organisations. By that, we mean you're referred to 4 organisations, and they'll have initial calls with you, and then they can tell you kind of what support or advice or signposting they're able to provide. And then to date, 13 innovations have actually been available for purchase on NHS Supply Chain. So this next slide is just a little bit of testimonials kind of from innovators about going through the service. I won't talk to this much because you'll be able to see it when you receive the slides, but yeah, the service has been pretty useful for a number of innovations. So that's the service website. If you'd like to use the QR code, that'll be useful to take you directly to the website, and feel free to sign up, and I'm sure you'll hear from me or one of my needs assessment colleagues when it comes to supporting you. And I'll just touch on a few more resources that are available within this kind of innovation ecosystem. So there is the AI and Digital Regulation Service. So if you are developing something that has a digital component in the kind of healthcare space, it's worthwhile looking at the AI and Digital Regulation Service website. They are a multi-agency collaboration which includes NICE, the MHRA, the Health Research Authority, and the Care Quality Commission. So it covers some really key stakeholders within this space, and they can really provide the best advice on what you need to consider when it comes to developing your innovation. I forgot to mention before that the MHRA are also on the NHS Innovation Service as well. So if there are very specific regulatory questions, we can refer you to the MHRA directly, and they can advise you on that. But yeah, I've provided a link there at the bottom. So to understand the regulations and the kind of best practice in this space for your digital tech, it's certainly worthwhile viewing the regulations and guidance for developers, because this space is ever changing as well. As I touched on at the start with the Accelerated Access Collaborative infographic, they do have a health technology pathway interactive resource. So this really is very comprehensive in terms of providing you with an understanding of how to create your idea for the NHS, all the way to what to consider when it comes to commissioning and adoption. So I'd certainly check that out from this presentation. I also touched on something called the NHS Innovation Accelerator. Again, this is another kind of program that can support innovators with developing ideas and spreading some of that across the UK. So when it comes to adoption, the program in particular is a close link between the NHS England and the Health Innovation Network, and includes a bespoke learning program with some mentorship and networking opportunities to help really scale that innovation that you're developing and link you up with the right stakeholders and NHS organisations to help support that. There's also something that's kind of what you may consider really at the late stage of development of your innovation. So this is the MedTech funding mandate, and that really aims to ensure patients in the NHS benefit from those innovations that are clinically effective and also cost effective. And by that means you'll have had to have gone through NICE and be kind of assessed by them, so through their different programs. But essentially, one of the key things to be included on this MedTech funding mandate is that you've got to be able to save costs and resources and make a return on our investment within 3 years. So there's very few things that are actually on this program, because it's very particular what they're looking for. And then that comes to the end of my presentation. I hope you have found this useful. And if you've got any questions, feel free to share them with Rusty and Chloe, and I'm more than happy to provide a bit of an FAQ to all the attendees from this event. Thank you so much, guys. Take care now. Bye-bye.
So that was Ben's presentation, giving a sort of a high-level overview of the innovation service. There is one question in the chat regarding timelines. So what are the usual timelines for having the innovation review to identify the needs and to be linked up with other organisations, which Steve from our organisation has replied to. So the needs assessment is done within 10 working days before being referred to support organisations. So Magda, I hope that answers your question. So next on the agenda is supply chain.
I think Leanne might be having some trouble joining.
Okay.
I can't see her on the list just yet. I think she's just joined now.
Hi, Leanne. Oh. Oh, Leanne, can you hear me?
Yeah, I can now.
Okay.
Technology.
No, no. Thank you very much for joining. So I'll hand over to you to give your presentation.
Wonderful, thanks. So good morning, everyone. Thanks again for asking me to come along and give you a really high level overview of how NHS supply chain operates and really how our teams support the NHS each day. So just by way of introduction, so I'm Leanne Waring. I'm one of the care pathway specialists within the care pathway team that work for NHS supply chain. Just by way of background, I am a registered nurse. And my clinical background before joining supply chain is in critical care, and I was a surgical practitioner in cardiothoracics in Sheffield. So next slide, please. So who are we? And firstly, I'd just really like to say that we're an extremely complex organisation with many moving parts. So in a nutshell, we manage the sourcing, delivery and supply of healthcare products, services and food for NHS trusts and healthcare organisations across both England and Wales. So that includes ensuring a resilient supply chain and ensuring that clinically all the products are assured as well as the services. So our value proposition is really the ability to consolidate purchasing, deliveries and invoices, and also to aggregate that whole NHS spend, which is approximately £6.5 billion. This includes a range of medical devices and clinical and non-clinical consumables, and we manage over 8 million deliveries to over 17,500 locations, and they're actually picked at requisition point. So what happens is that products are picked and packed and they put on big trolleys and they're actually delivered to that endpoint. So it might be theatres, A&E, etc. And that's all at agreed delivery times. So we provide clinically and quality assured devices and products across all the frameworks within supply chain. And again, we provide that resilience of a core list of products across our network. So that includes stock holding. So we have things that are in stock. And we also provide potential alternatives when we can't access certain things due to delivery issues. And again, where clinically acceptable. So we've got a team of clinicians that support that. So we also ensure product safety issues are dealt with really quickly. So for example, we've got governance around if we receive any field safety notices for the MHRA, they're managed accordingly. We deliver sustainable solutions and obviously, acknowledge that social value across the global supply chain. And we have, which I'm sure you'll be really interested in, we have a dedicated innovation team that collaborates with suppliers, trusts, to support that medtech mandate and novel innovations that deliver value-based benefits, which is where my space comes in. Next slide, please. So in the interest of time, I'm not going to cover this in detail, but I really want to highlight the productivity and clinical pathways elements of it selfishly, because that's where my role is pivotal. So productivity and clinical pathways is instrumental in supporting healthcare providers to increase their clinical capacity and to deliver innovations and value-based healthcare initiatives that result in both cash and non-cash releasing savings. So, increasing the patient throughput, reducing bed times, waiting lists, referral for diagnostics, etc. All these priorities are underpinned by delivering of savings, and our aim is to deliver the products and the savings whilst transitioning to that longer term efficiency and value delivery. So next slide, please. So how are we set up to support the system? So we've got dedicated teams that are focused on both hospital care, so your acute setting, and then that out of hospital care setting in terms of your community setting, so that we're really evolving the way in which we work. I am part of a new team, so the Care Pathway team. So we've got a team of pathway specialists, so I'm one of them, who support the implementation of care pathway changes to drive that real standardisation of patient care, which improves outcomes, increases revenue and deliver cost reductions through products and medical devices. So all things value-based procurement, really. Consolidation of clinical expertise. So we're bringing together about 80 clinicians that sit within our organisation, and we're all led by our clinical executive director, Michelle Johnson, who some of you might know. And that's really to ensure that we place patients' needs at the heart of our organisation and everything that we do. So we also have a dedicated team, so the voice of the customer team, which is really focused on ensuring that clinicians within the system, so all provider organisations, etc., have that voice and are able to, give the inform around category strategies and based on clinical and quality requirements. Next slide, please. So reducing health inequalities in medical products and devices. So there's a bit of detail within this slide. However, the key thing I wanted to highlight is that health inequalities is high on the agenda, and it's been built into the way in which we review and prioritise value-based procurement projects to ensure that all fair and equitable, so that it's all equitable across the NHS, to ensure that all patients get that fair opportunity to, access certain treatments. And just at the bottom of the slide to the left, you can see some of the successes that we've had in this space. So particularly around oxygen saturation monitoring, there's been a lot of work around that because saturation probes were failing in the ethnic minority. So we did a lot of work in terms of getting something on framework that suited that cohort of patients. Next slide, please. Right, now to the exciting bit. So easy for me to say, as this is the team I currently work within. So as I've already touched upon, my team sit within the customer directorate within NHS supply chain, and we've been stood up since about December, so we're a brand new function. We have a team of 11 clinical nurse advisors from a varied clinical background. So we've got nurses that predominantly have a clinical background in theatres, tissue viability, lots of varied skill sets within the team that are regionally based. So we've got a north and a south team that are led by 2 lead clinical nurse advisors, so Claire and Emma. And then we have 4 regional care pathway specialists and myself, who is a national role. So I specifically look at things that sit within what was HCTED, but is now the Specialised Services Device Programme. So a lot of that it sits with cardiology. So that's predominantly where my focus is. So next slide, please. So what's our approach? So all activity is driven by what we can see from clinical data. So for example, we're using hospital episode statistics, which for those of you that don't know, it looks at length of stay, typical costs, national averages across a wide range of procedures. So it can really inform us in terms of where certain systems are struggling in a particular area. So for instance, ENT pathway, we've got a number of opportunities with devices that can support that pathway in terms of reduction in bed stays from 5 bed days down to day case. So we then look to work with trust to understand where their clinical pathway speciality pain points are. In terms of those waiting lists, any backlogs, diagnostic waiting, etc. We then support the adoption of that suggested clinical pathway change to ensure that the system or the organisation provider can really recognise that value that sits behind that change. And at the core, really, of all that we do is the patient, and to drive the improvement in clinical outcomes enhancing the quality and productivity, which will achieve efficiency benefits, of course, for the whole system. Next slide, please. So really just to summarise, and I know that's been a whistle-stop tour, but the core priorities for my team is to drive the adoption of innovation products, devices and services, including those on the NHS England MedTech funding mandate policy within identified integrated care systems, care pathways. So at the minute we're working on APOS, which is used to avoid surgery for knee replacement. So we're working really closely with the Health Innovation Network to drive those opportunities across the system. So we also drive the adoption of clinical practice and publish value-based procurement studies, which I've included a link so that you can look at some of the opportunities that we are looking at as a team currently. And then develop partner-led value-based procurement studies that address these clinical pain points. So we're also asking for providers to reach out to us to discuss any issues that they're having, so that we can really understand if we do have something that can support those complexities. Next slide, please. So as I've said, I've put a link to both our team for some more information, and I've also put a link to the case studies that are within our website. So really, I'll open up for questions now. I know we haven't got a great deal of time, but just to say that if you have any other questions, then please do reach out. Thank you very much for listening.
Excellent, really good presentation. Thank you very much, Leanne. Has anybody got any questions for Leanne?
Stunned in silence. Information, I know.
Well, if there's no further questions, please do reach out to us if you have anything that you'd like us to pass on. But thank you very much for your time, Leanne. We'll let you go. But yeah, that was very, very interesting.
Wonderful. Feel free to reach out and have a great day.
Great. Thank you very much.
Bye.
Bye-bye. And then just to finish us off, so we have our case study that Catherine will go over. So this is PocDoc, and we've got a pre-recording from her just to go into a bit of detail about the innovation from sort of throughout its journey. So I'll let Hannah.
Good morning, everybody. My name's Catherine Kelly, and I'm one of the programme manager at Health Innovation North East North Cumbria, otherwise known as HINENC, and was very recently involved in the PocDoc project as part of the cardiovascular disease team. So I'd like to give you an overview of the work that we did, including some of the background, some context and the challenges we faced, what went well, and where PocDoc are now on their rapidly evolving digital journey. So what is PocDoc? PocDoc's a small point-of-care cholesterol test, similar in size to a COVID test. It requires a finger prick of blood dropped onto put into a capillary tube to drop onto the little plastic window, and it will provide a complete lipid test result delivered to either a smartphone or tablet in less than 10 minutes. This obviously negates the need for a visit to the GP surgery and then a wait for lab results to be returned. So in terms of funding, we secured funding from 3 different sources. The System Transformation Fund, which is a collaboration between the pharmaceutical company Novartis and NHS England, to look at improving the lipid pathway. The SBRI, or Small Business Research Institute, which is funding from the Accelerated Access Collaborative, or AAC, who provide funding to accelerate innovative technologies in the NHS and wider health and social care system to tackle unmet health and care needs. INHIPS, a unique collaboration between the AAC, the NHS the National Healthcare Inequalities Improvement Programme and England's 15 health innovation networks, and it's delivered in partnership with the ICSs. As you know, inequalities are unfair and avoidable differences in health across the population and between different groups within society. These include how long people are likely to live, the health conditions they may experience, and the care that's available to them. Some groups in society, particularly the socially excluded, those living in high levels of deprivation, those from Black, Asian and ethnic minority communities, can experience extreme difficulties, especially if they're in more than one of these seldom listened to groups. So HYNENG are delivering the CVD prevention programme across the North East and North Cumbria, which is a nationally mandated programme to align with the NHS long-term plan ambition, which is to prevent 150,000 heart attacks and strokes over the next 10 years by improving the detection and treatment of high-risk conditions for cardiovascular disease, which are atrial fibrillation or AF, hypertension, which is high blood pressure, and hypercholesterolemia, which is high cholesterol. And just a point of interest, high cholesterol as an independent risk factor causes cardiovascular disease and also accounts for 1/3 of all heart attacks, which means that it's vital that we're able to detect it and treat it. So our project scope, our ambition was to move cholesterol testing out of the traditional setting of a GP surgery and into either workplace testing, community screening, pharmacy screening, and then 2 smaller projects, one which looked at patients who had already had a heart attack or stroke, so secondary prevention patients who are on the CVD register but had missed their annual review, and then a separate arm which was looking at lung health check screening. So if we start with the workplace testing, we had almost 800 tests that were carried out in different workplaces, including HYNENG and Cleveland Police. 95% of responders being screened in the workplace said the healthy heart screen was more convenient than going to their doctor, and that's a figure that was reflected in all of the settings. In terms of the community, almost 2,000 screens were done in various different community settings, which included farmers' marts, women's centres, group screens, and that included hubs for Black Africans, South Asians and the Indigenous underserved white population. GP services in Newcastle and Middlesbrough Football Club, they both used buses to deliver healthy heart checks to areas of deprivation. So the community screening reached the highest proportion of people from ethnic minorities. Pharmacy services provided almost 1,400 screens and reached the highest proportion of white people at over 90%. And in terms of the secondary prevention CVD register, as I mentioned, this was a smaller pilot that looked at approximately 40 patients, but again achieved a high number of those who needed to be re-referred for lipid optimization. And we're still awaiting the results from the lung health check screening. So as we know, CVD is a major cause of health inequalities in North East North Cumbria, and it's a gap that we're working to reduce. Data taken from OHID, which is formerly Public Health England, shows that people living in the most deprived areas are 4 times as likely to die prematurely from CVD than those in the least deprived areas. So in response to this rather stark fact, HYNENG collaborated with system partners to address healthcare inequity by delivering a pilot project that aimed to increase the uptake of health checks within communities at the highest risk of CVD mortality. This was the INHIB programme and was a national programme that came to an end in April this year. So we aligned with the work that was being done around healthy heart checks in deep end practices and the most deprived areas within our region to use POCDOC for cholesterol testing. This meant that there was a move away from the traditional model of a patient attending a GP surgery for a venous blood test and then having to return for the results and treatment where necessary, to attending one of our clinics set up in the community and having their test and their result delivered within 30 minutes. It also allowed the clinical team using PocDoc to do other tests such as height and weight, but also, really importantly, to offer diet and lifestyle advice, as well as answer any of the questions the person may have. This model also cut down on GP healthcare professional time compared to a traditional model and made the process far more acceptable and convenient for the patient. So this slide is a summary of the combined results from the testing that was done across 3 community women's centres. The centres work with marginalised women to address health inequalities in both Middlesbrough and Gateshead areas. The women were given a PocDoc test along with height and weight, and the slide shows the reasons they were referred to their GP. As you can see, overall 29% were referred, but in one of the centres alone, the number of referrals was a shocking 64%. So this is just a snap of some of the other benefits. So the picture on the left-hand side shows a Nerve Fitness team along with 2 of the pharmacy techs from Hynenk, and they were just so grateful and welcomed them with absolute open arms. They were invited to their Iftari events, they were given food, flowers, and I'll just read you some of the feedback from the Nerve Fitness people. So first quote is, "We've been hosting heart health checks at our women's only space. We've been raising awareness of the importance of the checks to encourage uptake, shared to them in a language they understood. It has motivated our women to get more active and look after themselves, and we feel that this will bring a change in mindset and physical activity." And finally, women have had varied results. The feedback we have had is mainly that they are so glad they came. It was in a safe environment. Testing and advice had been thorough, informative and friendly. So for us, this was a huge success. So what worked well? We had very clear objectives from the outset and excellent, good, frequent communication between the PocDoc team and Hynenk, with weekly Teams meetings for half an hour on a Thursday morning. We had a lot of interest from different NHS bodies approached by the Hynenk team, and very good collaboration from PocDoc. So where there was a meeting requested, which there were many, there was always one person from Hynenk and a person from PocDoc to answer the more technical stroke training questions. Testing worked particularly well in corporate settings where there was an occupational health or wellbeing team available on site, or there was an at-home option available, so people could order a test and take it home to test themselves. And as you've seen, some of the community work was outstanding. So successes and outcomes, we were nominated for an HSJ award earlier this year. The category was population health through digital. We've developed a big suite of materials now, which includes a process map, a healthy heart check leaflet for patients. We have posters and a plethora of training materials for healthcare professionals. Steve Roast, who's the CEO of PocDoc, has just been appointed as member of NHS SME Advisory Board, and for PocDoc now has integration with the NHS app, which is the first digital solution at home to integrate with the NHS app. So obviously we had many challenges along the way. There was the need for some technical tweaks, including the development of different landing pages for secondary prevention and primary prevention patients, as there's different guidelines for each set of patients. Originally, results didn't go directly to the patient records or the NHS app, so we relied on the patient going to the GP with a paper letter that was given to them by us or the clinical team. It was quite a clinical burden on the high-NENC team who were actually doing the physical checks, and at the start there was a lack of training, but that's now been rectified. We did spend a lot of time with a lot of different organisations, and that didn't always translate into participation in the programme. So finally, where are PocDoc now? So they go from strength to strength. Currently the UK's fastest growing diagnostic startup, with plans to launch in the Middle East this year and the US at the end of next year. As I said, they're the first at-home diagnostic service to integrate with the NHS app. And here's just a few examples of where they are within England. So they have a contract with Cumbria Health. They're still live in NENC and West Yorkshire. Contracts in Cambridge and Peterborough. And again, they're available in a plethora of pharmacies for at-home testing. So I'm sorry I am not there in person to answer any questions, but if you have any questions, require further information or clarification, please do email me on the address below. And thank you for listening.
Excellent. So Tracy, who is part of the PocDoc team, is on the call. So if anybody has any questions, please do let us know. And Tracy will be happy to answer them. I think everybody's really saturated with information. So if anybody does need questions, there's some email addresses that you can get in touch with that are on some later slides. So that sort of wraps up our session for today. So the NHS as a market. The slide sort of shows the details of the innovation pathway. So this is the upcoming sessions. That will be on the 17th of October, so in 2 weeks' time. So we'll go over the innovation pathway, sort of that diagram that I showed earlier, and give you an idea of idea assessment, how to develop a value proposition. We'll touch on sustainability and PPIE, and then talk about evaluation. So one of our experts will talk about clinical studies versus real-world evaluations, and then sort of next steps to get in touch with us at Health Innovation and our engagement form and process. So next slide, please. So thank you very much for attending today. So if you want to get in touch with us, have a look at our website. And as Simon detailed earlier, we're part of the Tees Valley Innovation Challenge. And we have a healthcare challenge out there already. So if anybody's interested in applying or wants some further information, please do have a look at the website. Any further questions, please get in touch with myself or Chloe on the email addresses below. And then if there's no more questions, we'll hopefully see you at the next session. Thank you very much for attending.